Contrasting the two main chemotherapy regimen in pancreatic cancer, FOLFIRINOX versus Gemcitabine-Abraxane. Hello, this evidence-based content is prepared by Saboor, fellowship-trained consultant surgeon, and if you or someone you care about has just been diagnosed with pancreatic cancer and your oncologist is discussing chemotherapy options, you're in the right place. I know hearing terms like FOLFIRINOX and Gemcitabine-Abraxane can feel overwhelming when you're already processing a cancer diagnosis, but understanding these treatment choices is one of the most important conversations you'll have. FOLFIRINOX is a combination of 4 chemotherapy drugs: fluorouracil, leucovorin, irinotecan, and oxaliplatin. It's given through an intravenous infusion, and that FOL stands for folinic acid, another name for leucovorin, F for fluorouracil, IRIN for irinotecan, and oxy for oxaliplatin. Gemcitabine-Abraxane combines gemcitabine with nab-paclitaxel, which is also called Abraxane, a special formulation of chemotherapy bound to albumin proteins. Why does this matter to you personally? Because these are the 2 most effective first-line treatments we have for advanced pancreatic cancer, and the choice between them directly impacts your treatment experience and outcomes. In the landmark PRODIGE-4 trial involving 342 patients with metastatic pancreatic cancer, FOLFIRINOX improved median overall survival to 11.1 months compared to 6.8 months with gemcitabine alone. Now, what does this look like in real terms? That's an improvement of about 4 months in median survival. The 1-year survival rate was also notably different. Patients on FOLFIRINOX had better outcomes with a hazard ratio of 0.57, meaning their risk of death was reduced by 43% compared to gemcitabine alone. For Gemcitabine-Abraxane, the MPACT trial of 861 patients showed median overall survival of 8.5 months versus 6.7 months with gemcitabine alone. Now here's where it gets interesting. While FOLFIRINOX appears more effective on paper, there's actually never been a head-to-head randomized trial directly comparing these 2 regimens. You're probably wondering why not, right? It's a valid question to ask your oncologist. What we do know from the SWOG S1505 trial, which looked at potentially resectable pancreatic cancer, is that 2-year overall survival was essentially identical at 47% with FOLFIRINOX and 48% with Gemcitabine-Abraxane. This suggests that in certain situations the outcomes may be more similar than the individual trials suggest. The key takeaway? FOLFIRINOX generally shows stronger efficacy data in metastatic disease, but the trade-off comes in toxicity and who can actually tolerate it. FOLFIRINOX was studied in patients with an ECOG performance status of 0 or 1. It is important to understand the concept of performance status. It is a graded scale developed by a group of oncologists to determine activity levels, see the chart. Now, what does this mean in practical terms? An ECOG 0 means you're fully active and able to carry on all your usual activities without restriction. ECOG 1 means you're restricted in physically strenuous activity, but still able to do light work. If you're spending more than half your waking hours in bed or a chair, you likely won't be offered FOLFIRINOX. Gemcitabine-Abraxane has been studied in patients with a broader range of fitness levels, including those with ECOG performance status of 2, which means you're capable of self-care, but unable to work, and up and about more than 50% of waking hours. There's even data for a modified every 2-week schedule in patients who might not tolerate the standard weekly dosing. You can do the math here. If you're feeling quite weak or debilitated from your cancer, Gemcitabine-Abraxane might be your only realistic option for combination chemotherapy. FOLFIRINOX has higher rates of severe side effects across the board. In the PRODIGE-4 trial, grade 3 or 4 neutropenia, that's dangerously low white blood cell counts, occurred in 46% of patients on FOLFIRINOX versus 21% on gemcitabine alone. Febrile neutropenia, which means fever with low white cells requiring hospitalization, happened in 5% versus 1%. But here's where it gets interesting. Despite greater toxicity, FOLFIRINOX actually improved global health status and quality of life compared with gemcitabine alone in the same trial. For Gemcitabine-Abraxane, the MPACT trial showed grade 3 or 4 neutropenia in 38% of patients, fatigue in 17%, diarrhea in 6%, and peripheral neuropathy, that's numbness and tingling in hands and feet, in 17% of patients. FOLFIRINOX causes more gastrointestinal issues, grade 3 or 4 diarrhea in 13% versus 2%, with gemcitabine and vomiting in 15% versus 8%. Sensory neuropathy occurred in 9% with FOLFIRINOX. The neuropathy from oxaliplatin in FOLFIRINOX is often cold-triggered. You might have difficulty handling cold drinks or experience shooting pains when touching cold objects. Gemcitabine-Abraxane's neuropathy is different. It's cumulative and related to the total dose of paclitaxel you receive. This is something to discuss with your doctor about whether doses might need adjustment over time. Standard FOLFIRINOX is given every 2 weeks. You'll come in for an infusion that takes several hours, and you'll go home with a small portable pump that continues infusing fluorouracil for 46 hours. This means carrying a pump home with you, which some patients find intrusive to their daily life. Modified FOLFIRINOX uses lower doses and may be better tolerated with similar effectiveness. Median overall survival was 11 months with grade 3 or 4 neutropenia in 48%, which is actually similar to standard dosing. Gemcitabine-Abraxane is typically given on days 1, 8, and 15 of every 28-day cycle. That's 3 clinic visits per month for infusions that take a few hours each. There's also a modified every 2-week schedule available that some patients tolerate better. FOLFIRINOX requires prophylactic G-CSF support to boost white blood cell production, frequent clinical visits for laboratory testing, ready access to intravenous fluids, and close surveillance for common toxicities like fatigue, nausea, vomiting, diarrhea, and neuropathy. You need to be prepared for potentially weekly blood tests at least initially to ensure you're safe to continue treatment. First, have an honest conversation with your oncologist about your ECOG performance status. Ask them directly. Based on my current fitness level, am I a candidate for FOLFIRINOX, or would Gemcitabine-Abraxane be safer for me? Document your daily activity levels for a few days, how much time you spend upright and active versus resting, and bring this information to your appointment. Second, if you're a candidate for FOLFIRINOX, clarify the supportive care plan. Ask, will I receive prophylactic G-CSF injections? How will we monitor for infections? What's the plan if I develop fever? Make sure you understand that fever above 100.4 degrees Fahrenheit or 38 degrees Celsius while on chemotherapy is a medical emergency requiring immediate evaluation. Third, understand the logistics. For FOLFIRINOX, you'll need someone to drive you home with the infusion pump, help you manage the pump at home, and understand disconnection procedures. For Gemcitabine-Abraxane, plan for 3 infusion days per month and arrange transportation, since fatigue can make driving unsafe. Fourth, prepare your home environment. If starting FOLFIRINOX, minimize cold triggers, have room temperature drinks available, use oven mitts for refrigerators, avoid ice. Stock anti-diarrheal medications like loperamide. For Gemcitabine-Abraxane, set up a comfortable space for post-infusion rest, as fatigue peaks in the days following treatment. Given that FOLFIRINOX and Gemcitabine-Abraxane have never been directly compared in a randomized trial for metastatic disease, what factors make you recommend one over the other for my specific situation? If I start on one regimen and don't tolerate it well, can we switch to the other? What would that decision be based on? What are the specific criteria you'll use to decide if I need a dose reduction? How will that affect effectiveness? For FOLFIRINOX, am I a candidate for modified FOLFIRINOX with lower doses? What's the difference in expected outcomes? For Gemcitabine-Abraxane, if I develop neuropathy, at what point would we consider stopping the Abraxane component and continuing gemcitabine alone? How many cycles of treatment are you planning? What determines when we stop? Call your oncologist immediately or go to the emergency room if you develop fever of 100.4 degrees Fahrenheit or 38 degrees Celsius or higher while on chemotherapy. This is febrile neutropenia until proven otherwise and requires immediate evaluation and antibiotics. Severe diarrhea with more than 6 bowel movements per day, or diarrhea with dizziness suggesting dehydration. Uncontrollable nausea or vomiting lasting more than 24 hours. Sudden worsening of neuropathy, especially if affecting your ability to walk or use your hands. Any signs of bleeding, blood in stool or urine, unusual bruising. Severe abdominal pain, which could indicate complications. New confusion or difficulty speaking, which could indicate stroke or other complications. For FOLFIRINOX, your blood counts typically reach their lowest point or nadir around 10 to 14 days after each infusion, then begin recovering. You'll likely feel worst during this nadir period. Most patients find that days 3 through 10 after infusion are the most challenging. For Gemcitabine-Abraxane, fatigue often peaks 2 to 3 days after each infusion. Neuropathy develops gradually over multiple cycles. You should report any numbness or tingling early, as catching it early allows for dose adjustments before it becomes severe or permanent. If you're worried about someone you love on these treatments, trust your instincts. If they seem significantly more unwell than usual, are confused, or develop fever, seek medical attention. These concerns are completely normal and understandable. Never hesitate to call the oncology team. FOLFIRINOX generally offers superior survival outcomes, but requires excellent fitness levels and comes with higher toxicity. Your next step: assess your performance status honestly with your oncologist and ask which regimen matches your fitness level and treatment goals. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on pancreatic cancer chemotherapy options. The National Comprehensive Cancer Network, NCCN Clinical Practice Guidelines for Pancreatic Adenocarcinoma provide detailed treatment algorithms. The American Society of Clinical Oncology, ASCO, offers patient-focused guidelines on metastatic pancreatic cancer treatment. Up-to-date patient education materials on pancreatic cancer chemotherapy. The Pancreatic Cancer Action Network provides comprehensive support resources. Cancer Research UK offers detailed information on chemotherapy side effect management. All links to these resources are provided in the video description below. Thanks for watching.